So again, good morning. Uh, we're going to look at cardiomyopathies, and we're going to do the definition, look at signs and symptoms, classification, the different causes for the different cardiomyopathies, and then the echo features. We're going to end with the echo features. All right. And when we say cardiomyopathies, we're talking about heart muscle disease, and there's a wide variety of heart muscle disease. Um, and they usually result in deterioration of the myocardial function, resulting in heart failure, and the patient presentation with heart failure, usually shortness of breath. uh, Start with shortness of breath with exertion. You get shortness of breath at rest, uh, peripheral edema, so the legs are swollen. If you look at the sacral area, uh, if the patient is bedridden, then you'll have swelling in the sacral area. Arrhythmia, so patients with cardiomyopathy, one of the mode of death, or one of the more common mode of death, is arrhythmic death. Ventricular tachycardia, ventricular fibrillation, and sudden cardiac death as well. So the different class of cardiomyopathies that we're going to look at is dilated cardiomyopathy. The heart is enlarged, usually the LV, and as a result of that, you have a reduction in the ejection fraction. We're also going to look at hypertrophic cardiomyopathy, where the heart muscle is thickened, and initially they will have diastolic dysfunction, and they can also develop systolic dysfunction as well. Then restrictive cardiomyopathy, where you have infiltration into the myocardium. Usually, the myocardium is infiltrated by multiple substances, which again result in diastolic dysfunction and heart failure. Then arrhythmogenic right ventricular cardiomyopathy, very interesting type of cardiomyopathy, usually involve just the right ventricle, where the right ventricle is infiltrated by fibrofatty tissue, and as a result, the normal myocardial function is reduced, and those patients usually present with arrhythmia as well. Okay, and then non-compaction of the left ventricle, that is the muscle layer, did not develop properly. There's a lot of trabeculation and recesses, and you have a reduction in the ejection fraction as well. So those are the cardiomyopathies that we're going to look at. All right, so the first one is the dilated cardiomyopathy, where the chambers of the heart are dilated. When you look at the left ventricle is dilated. The left atrium may be dilated as well. The right side might also be dilated. So you'll have a decrease in the ejection fraction, because the dilatation of the LV results from a reduction in the ejection fraction. So the LV gradually gets larger and larger. Okay, so we talk about a sphericity index, where the index is in the short axis view. You measure the long axis and you put that over the short axis. So the length of the long axis to the length of the short axis, we're talking about a short axis view. Okay, and if that's the normal, should be greater than or equal to 1.5. And then when you have a dilated cardiomyopathy, the LV mass is increased as well. When we talk about the sphericity index, let me I'm just going to go over that, because you might see that somewhere. So let me just draw it. So in the short axis, okay, and usually short axis at the base, okay, you know, the short axis, the heart looks somewhat like that. So you're going to measure the long axis, which is from the anterior wall down to the inferior wall. So that's the long axis. You measure that. And then you measure your short axis, which is from septum to the lateral wall. So if you call the measurement of your long axis L, and the measurement of your short axis S, then this first the index is, call this first the index, call first the index R. This first the index is equal to L over S. So you just do the measurement and you, so it's the measurement of L. So in the short axis view, you measure the long axis, and then you're going to measure the short axis. This first, if the index is equal to L over S, it should be, the normal should be greater than or equal to 1.5. So when you have a dilated cardiomyopathy, you get this first, the index approaches 1. What you're saying is that this short axis is getting larger and larger, so that the ratio approaches 1. You also get an increase in the LV mass. So everything becomes dilated and flabby and, you know, just not functioning properly. So that is your dilated cardiomyopathy. All right, so what are some of the causes of a dilated cardiomyopathy? So one of the most common cause for a dilated cardiomyopathy is myocardial infarction or ischemia. And the mechanism for that is when the heart muscle dies, or if the heart muscle is not getting enough blood flow, we talk about remodeling. The heart muscle remodels and it becomes thin and it dilates. So that's one of the problems with heart attack. Myocarditis, you also get a thinning and dilatation of the myocardium. So myocarditis is just an inflammation of the muscles, and usually viral, but other things can cause it. But it's usually a viral cause. So we talk about the Coxsackie-B virus, which is one of the most common one, enteroviruses. Okay, but if you remember, when someone develops a rheumatic heart disease, one of the first thing that occurs is you get a rheumatic myocarditis. Okay, so the heart muscle becomes inflamed. You can also get alcoholic cardiomyopathy, which is a very common cause. Patients who drink excessive amount of alcohol, it can damage the heart muscle. The heart muscle can thin and dilate. Hemochromatosis, that is excess of iron buildup into the heart muscle. Peripartum cardiomyopathy, usually in the third trimester and sometimes just after delivery. These mothers can develop a cardiomyopathy, and that's fairly common as well. So in the third trimester or just after delivery, pregnant patients will develop increase in shortness of breath, increased leg swelling. You know, if you're not careful, you may think it's a normal part of pregnancy. But if the symptoms are excessive, then you should do additional evaluation using echo to make your assessment. Sarcoidosis also can cause a dilated cardiomyopathy. This is a multi-system disease. Other causes includes acquired immunodeficiency syndrome, AIDS. So HIV can also cause a dilated cardiomyopathy, and chemotherapeutic agent. That is why when patients have, say, a breast cancer or a lung cancer, and they're going to put them on certain type of cancer drugs, they usually send them to the echo lab to evaluate them before, during, and after the use of these medications. And the medications that commonly will cause a cardiomyopathy is doxorubicin or adriamycin and cobalt. So you have to remember this. Also, tachycardia-induced cardiomyopathy. We see this a lot, especially patients who develop atrial fibrillation. So patients who develop atrial fibrillation, sometime within a few days to weeks, they can develop a cardiomyopathy. And if you catch them early, treat them, and convert the heart back to normal, the cardiomyopathy can resolve. But if you wait too long, then it becomes permanent. So be careful of that. In South America, we talk about Chagas disease caused by Trypanosoma cruzi. It's another, distinctive cause, usually in South America. Thyrotoxicosis, patients with hyperthyroidism can also develop a cardiomyopathy. Some of this may be due to tachycardia-induced cardiomyopathy, but some may result just from the hyperthyroid state. Because when a patient presents with hyperthyroidism, they usually have a tachycardia, either a sinus tachycardia or atrial fibrillation, and that can in itself can give rise to tachycardia-induced cardiomyopathy. So again, when we say a dilated cardiomyopathy, everything is dilated, everything is the chamber size is increased. So if you look at your M mode, and you do your measurements, you can see that this is across the LV cavity. You can see that the LV cavity is dilated. So, all right. And usually the ejection fraction is less than 40%. So these patients usually, when you do your ejection fraction, usually less than 40%, you get a dilated left ventricle, dilated left atrium, and the right side also will be dilated, right atrium and right ventricle. And the mitral annulus will be dilated, and that's usually the mechanism of mitral regurgitation in these patients, because they commonly have mitral regurgitation because of dilatation of the mitral annulus. And if the ejection fraction is pretty low and the apex is not moving, they can also present with an apical thrombus, blood clots in the apex. So again, you do your measurement. This is, you measure the left atrium, and the left atrium in this individual is 6.26, very dilated. You should do the left atrial volume index, however, it's more accurate. And this would be a good view to do your sphericity index. Again, when we say you do your sphericity index, so you're going to measure the long axis. Okay, whatever you get, you just measure it. And then you measure the short axis. Okay, the normal is the long axis to the short axis should be greater than or equal to 1.5. When you develop a dilated cardiomyopathy, the dimension, the short axis dimension start to approach that of the the long axis dimension. So this first, the index approaches 1. Okay. All right. So that is your so-called first the index that we've been talking about. Okay. All right. So again, all the chambers are not all, but especially the LV will be dilated, and your dilatation of the mitral annulus. So you do get some amount of mitral regurgitation because of dilatation of the mitral annulus, poor coaptation of the mitral valves, and mitral regurgitation. Okay, this is an apical 4-chamber view. You can use your Doppler to calculate stroke volume and cardiac output. Okay, so you can calculate cardiac output for these patients. So again, just a reminder, to get the stroke volume, it is 0.78 times d squared times the LVOT TVI. Okay, so that is the stroke volume. And if you multiply your stroke volumes times the heart rate, then you get cardiac output. So remember your definition. Cardiac output is stroke volume times heart rate. The stroke volume, that is the volume of blood pumped out of the ventricle per beat, is 0.785 times d squared times the TVI, LVOT TVI. And, it may not be reduced at rest, but especially with exertion, you'll get a reduction in the cardiac output. Pulmonary artery pressures, patients with dilated cardiomyopathy, the more sicker they get, the more elevated is pulmonary artery pressures. So, of course, to get your pulmonary artery pressures, it is the TR gradient plus the right atrial pressure. So you can either do your pulmonary artery systolic pressure, or you can do the mean pressure. The mean pressure is probably more meaningful to practicing physicians. And then if you want to demonstrate, because remember that all patients with systolic dysfunction have diastolic dysfunction. All patients who have systolic function is going to have diastolic function. And you can grade the degree of diastolic dysfunction. Also, you can get an assessment of the filling pressures. Remember, for you to develop heart failure, that means the heart is failing as a pump. And when the heart fails as a pump, the first thing that happens is that the filling pressures goes up. The left ventricular end diastolic pressure goes up. And we can evaluate the left ventricular end diastolic pressure by looking at EE prime, and this is specifically the medial EE prime. And if it's greater than 15, it tells you that the LV filling pressure is elevated. Okay? You cannot have heart failure unless the filling pressures are elevated. Again, for muscle disease, because dilated cardiomyopathy is a muscle disease, so you're going to have a reduction in your E prime. So the E prime should be less than 7 centimeters per second. And you can also get a reduction because it's a systolic problem as well. So your S prime will be reduced. When you look at your deceleration time, it's going to be short, probably less than 160. And if your E prime is elevated, you have a short deceleration time. These patients are very sick. those numbers suggest a worse prognosis for your patient. Short deceleration time and a very high EE prime. Okay. So again, everything is dilated. The mitral annulus is also dilated. So you have poor coaptation of the mitral valve and mitral regurgitation. And sometimes you can have significant mitral regurgitation. Okay? So in this case, it's at least moderate. You can see that it's very dense. You have to do other maneuvers to determine the severity of the mitral regurgitation, but it looks pretty dense. It's at least probably moderate. If when you do your mitral inflow, you can also determine the degree. It helps you to determine the degree of diastolic dysfunction. It's not uncommon for these patients to have what we call restrictive physiology or grade 3 diastolic dysfunction. Remember, restrictive physiology and grade 3 diastolic dysfunction, your E to A ratio is greater than 2. E to A ratio greater than 2, that is restrictive physiology, grade 3 diastolic dysfunction. And pulmonary vein flow, mainly if the patient have mitral regurgitation, you want to look at the severity of the mitral regurgitation, but also patients with a dilated cardiomyopathy, reduction in your LV systolic function, the S prime velocity is usually reduced. So you get a reduction in the, sorry, not S prime, the S. So you're going to have your systolic and diastolic velocity. These are pulmonary vein flow. So you'll get a reduction in the systolic component. Now we're going to move. So that is dilated cardiomyopathy. Okay, we see a lot of those patients coming to the echo lab. So you should have a fair understanding, how to evaluate these patients and what you're looking for. We're going to move on to hypertrophic cardiomyopathy. Again, fairly common. When we talk about specifically hypertrophic cardiomyopathy, we're talking about a primary disease of the myocardium in which a portion of the myocardium is thickened. You can have secondary hypertrophic cardiomyopathy where, from hypertension, the patient may have aortic stenosis, anything that increase the afterload that, will a lot of time will cause the myocardium to hypertroph. But this is a primary disease of the myocardium. The myocardium does get thickened because of some muscle disease. So a portion or all of the myocardium may be thickened, okay? Again, when you see a thickened heart muscle, before you call it a hypertrophic cardiomyopathy, you have to rule out secondary causes. Does the patient have hypertension? Does the patient have aortic stenosis? Or, something of that nature. For your hypertrophic cardiomyopathies, when you look at the muscles, under the microscope, the sarcomeres, which is a contractile element, they're increased in size. So the contractile elements of the myocardium, they are increased in size. And you also get what we call myocardial disarray. That is disruption in the normal alignment of the muscle cells. So, this is not hypertrophy secondary to hypertension. This is a muscle disease where the sarcomeres increase in size and you have myocardial disarray. So it is specific. All right. So it is usually, for hypertrophic cardiomyopathy, it is usually a mutation in one of the 10 sarcomeric genes that results in a mutated protein in the sarcomere. It's autosomal dominant, okay? So there are 10 sarcomeric genes and there's usually a problem in one of them. which result in a mutated protein, resulting in the sarcomeric problem. The prevalence in the general population is 0.2 to 0.5%. Okay, and there are different types of hypertrophic cardiomyopathy. You can have this asymmetrical septum, where the septum is tremendously enlarged compared to the other portion of the heart muscle. Or you can have concentric, all areas are thickened, the septum and the posterior wall is thickened just alike, and the apex. Or you can have just an apical hypertrophy, where just the apex is thickened. They love apical hypertrophy in exams, so you have to be aware of that. They love asymmetrical septal as well. Or you can just have an LV free wall hypertrophy. So asymmetric septal hypertrophy, I said that they love this one. So it's a septal bulge, or a bulging of the septum, is the most common type. And you tend to get anterior position of the mitral and the papillary muscles. And these patients commonly present with mitral regurgitation, okay? So you have an anterior position of the mitral valve and papillary muscles, and you get what we call SAM. So some people think it's the anterior position of the mitral leaflets and the papillary muscles which give rise to SAM, which is systolic anterior motion of the mitral valve. So what we are saying here is that in systole, the mitral valve moves anteriorly, and it actually blocks the left ventricular flow tract, giving rise to obstruction. So if you see SAM, you usually have obstruction because the mitral valve moves anteriorly into the left ventricular flow tract and cause an obstruction. Again, we said they commonly have mitral regurgitation, and because of the SAM, they get left ventricular flow tract obstruction. It's a dynamic process. So, all right, so two-dimensional echo on top, your M-mode echo on the bottom, and if you look at thing, you can see that the RV wall looks a little thickened. This is the RV cavity. The septum, if you've been looking at M mode, you know that this septum is very thickened, and you can look at your measurements on the vertical axis, which gives you distance or displacement or length, and you can see if each of these is 10, this is almost 30, so it's very thick. And then the posterior wall is also thick. But look what happened inside your LV cavity. This is the mitral valve, okay? You know that the mitral valve, so look at your ECG on the bottom, the mitral valve opens and diastole, opens and diastole, opens and diastole. But in systole, you have your anterior displacement of the mitral valve. In systole, look at the ECG, systole is from the onset of the QRS to the T wave. So in systole, you have anterior displacement of the mitral valve, which it actually impinges on the septum. So anterior displacement of the mitral valve impinges on the septum. Anterior displacement of mitral valve impinges on the septum. For it to do that, then it's going to block the left ventricular flow tract. Okay, because remember, if you remember what your parasternal long axis looks like, if the mitral valve is going to move up to the septum, then it's going to block the left ventricular flow tract. So it will give obstruction. Okay, and you'll see something looking like this. So in systole, the mitral valve moves to the septum. Remember that blood leaves from the LV cavity in systole through the left ventricular flow tract and across the aortic valve. So if this is happening, if this is occurring in systole, then blood cannot get out of the heart. So when you do your gradient across the left ventricular flow tract, it's going to be tremendous. Again, this is septum and SAM. So SAM, systolic anterior motion of the mitral valve, SAM. So they like this in exam. Okay, So if you do your color across the left ventricular flow tract, you're going to get turbulence, suggesting obstruction. Okay, so short axis, you can see everything thickens. Okay, everything thickens. Okay, so remember what we talked one of the things that was mentioned was there's an abnormal position of the mitral valve and the papillary muscle, which gives rise to the anterior systolic anterior motion of the mitral valve, causing obstruction. So in systole, your mitral valve moves up to the septum, blocking the left ventricular flow tract. So SAM. So they love that in exams. Okay. So if this is a transesophageal echo, and you can see the SAM, systolic anterior motion, the septum, the mitral valve impinges on the septum. Septum is huge, very thickened. So in systole, it impinges, blocking the left ventricular flow tract. If you were to do, say, a myomectomy, so you can do either surgical myomectomy or you can do alcohol septal ablation, reduce the size of reduce the size of the septum, and as a result, reduce the obstruction. Okay. Again, so this is you can do alcohol septal ablation. So it's another transesophageal echo showing you SAM, systolic anterior motion of the mitral valve. It moves towards the septum, blocking the left ventricular flow tract. You do your color flow, you get some MR, you get turbulence across the left ventricular flow tract. If you do alcohol septal ablation, then you can see you don't have the SAM systolic. In systole, when the mitral valve closes, it doesn't move towards the septum. There is no obstruction of the left ventricular flow tract. And when you do your color flow, you can also see there is no turbulence there. All right. So apical hypertrophy, apical hypertrophy cardiomyopathy. They love this in exam as well. Just the apex is thickened, and you give contrast. They recommend that you give microbubble contrast to make the diagnosis, and you get the so-called ace of spade. They love this in exam, so you have to know it. So this is your so-called ace of spade. Okay, so it's just the apex is hypertrophed, and you give microbubble contrast, and you get the so-called ace of spade. All right, so what are the other echo and Doppler features of hypertrophic cardiomyopathy? So the muscle is going to be thickened, and by do your measurements, you can determine the distribution of the thickening, whether it's concentric, whether it's septal, apical, free wall, whatever. So you just do your measurement. You also have to get your ejection fraction. Usually it's normal, but some of these patients can present with reduced ejection fraction. You may also get RV hypertrophy as well. You can also get obstruction of the right ventricular flow tract, so be aware of that. And then you have to size the left atrium. So you do your left atrial volume index. All right, so remember how to do your left atrial volume. Okay, so you're going to do your apical 4-chamber view. It's an area length method, and your apical 2-chamber view, area length method. You multiply the area in 1 to the area in 2, and you're going to divide by the shortest length, and you're going to multiply that by 0.85. So to get your left atrial volume index. All right, so again, you need to do your diastolic function assessment. So you have to go through your different parameters. You look at your mitral inflow, look at your tissue Doppler to determine if there is diastolic dysfunction, and the grade, pulmonary artery systolic pressure. So you have to do that. You have to check for left ventricular flow tract obstruction. Sometimes you have to do it, if you suspect hypertrophic cardiomyopathy, you should do it at rest and with Valsalva. And sometimes you have to even exercise the patient. You may have to put them on the treadmill, or you can let them do a few, jogging in place, and then quickly look at the left ventricular flow tract to see if the velocity and hence the gradient increase with exertion. So you have to look at the mitral, because we think that there is a problem with the mitral valve and the papillary muscle insertion in some of these patients. So you have to evaluate the mitral valve and papillary muscle carefully, and then look at the mechanism and the severity of the MR. You may need to do TE. You may need to do transesophageal echo, especially if you're going to do surgical or even alcohol septal ablation. And if you make a diagnosis of hypertrophic cardiomyopathy in a patient, you have to screen the relatives. First-degree relatives should be screened. Not only that, once you make the diagnosis, then you can do genetic studies on these patients and then screen the first-degree relatives. All right. So this again, when you evaluate these patients and you look at the mitral inflow, okay, this may suggest that the mitral inflow is normal, E bigger than H, but it may be pseudo-normal. When you look at your pulmonary vein flow, systolic flow greater than diastolic flow, atrial reversal, this looks fairly normal. Okay, when you look at your tissue Doppler imaging, you look at your E prime and your A prime. Again, your hypertrophic cardiomyopathy is a muscle disease, so you expect your E prime to be reduced. So it's not uncommon to get a big E and a small a. Okay, so it may be a pseudo-normal pattern, but if your E to A ratio is greater than 2, then that's your restrictive physiology. You may get your so-called L wave, suggesting elevated filling pressures. Again, you're going to get very reduced E prime because it's a muscle disease. Okay. All right. So the other cardiomyopathy is your so-called restrictive cardiomyopathy. So when we say restrictive cardiomyopathy, that is the heart muscle is usually infiltrated with something. One of the most common one is amyloidosis. So because of the infiltration of the myocardium, it becomes rigid. It's non-compliant. Okay? It's rigid. The heart muscle is restricted from filling with blood. So you have primary causes and secondary causes. Primary cause would be something directly infiltrating the muscle, and then secondary causes, patient has some other disease process which cause the heart to be secondarily involved. So some of the primary restricted cardiomyopathy, so the heart muscle is infiltrated with these substances, the Loeffler's endocarditis and endocardial fibroelastosis. So the heart muscle become infiltrated. Okay, they're not very common. So the primary cause is not very common, but you have to still know them. Secondary causes now One of the most common is the amyloidosis. The patient will have amyloidosis all over, and then the heart becomes infiltrated with amyloid. You can have hemochromatosis, again, iron. The patient may have a problem with iron increasing in the body, and then the heart also become infiltrated with iron, and the heart muscle becomes rigid, stiff. Sarcoidosis can also cause a dilated and a restrictive cardiomyopathy, post-radiation fibrosis, carcinoid scleroderma, Fabry's disease, pseudoxanthoma elasticum can also cause it. When someone with a restrictive cardiomyopathy, the LV systolic function may be normal. So the LV systolic function may be normal, may be depressed, but it may be normal. The LV dimensions may be normal. The measurements of the chamber size may be normal. The wall thickness may be mildly thickened or mild to moderate, so be aware of that. Commonly, you get biatrial enlargement. The atria, right and left, is enlarged. It's very common. So it's not unusual to see a patient with restrictive cardiomyopathy looking somewhat like this, somewhat thickened muscle, pericardial effusion, and the atrium is enlarged. Okay. So when you do your Doppler evaluation of the mitral inflow, so you can get a pseudo-normal pattern. Your E velocity, a lot of time greater than 1, A velocity less than 0.5. If they have restrictive physiology, then the E to A ratio will be greater or equal to 2. If they have restrictive physiology, greater than 2. It's the deceleration time, a lot of these patients less than 160, IVRT less than 70. So the restrictive physiology, when you have restrictive physiology, your deceleration time is going to be short, IVRT is going to be short, and your E to A ratio is greater than or equal to 2. So you may see something looking like that. Very big E and a small a, restrictive physiology. Okay. When you look at your pulmonary vein flow, you get a small systolic component and a large diastolic component, and an increase. Your atrial flow reversal velocity and duration will be increased. So when you look at your pulmonary vein, you get a small systolic component, a large diastolic component, and then your atrial flow reversal will be increased. You get an increase in both velocity and duration of the atrial flow reversal. Hepatic vein flow, you get increased diastolic flow reversal and inspiration. Okay, so remember, they always like for you to distinguish between a restrictive cardiomyopathy and a constrictive pericarditis. That's what you're going to get in all exams. They want you to distinguish both. With constrictive pericarditis, you get an increase in your atrial flow reversal in expiration. With restrictive cardiomyopathy, you get an increase in your atrial flow reversal in inspiration. All right, so this is one. But this is a muscle disease, whereas your constrictive pericarditis is a pericardial disease. So in your restrictive cardiomyopathy, the E prime is going to be very reduced, telling you that it's a muscle disease you're dealing with. So your E prime velocity usually less than 7 centimeters per second. And the thing that they're going to bring in your exam is your increase atrial flow, diastolic velocity, increasing your atrial flow velocity with inspiration. And because it's a muscle disease, your E prime is less than 7 centimeters. Okay, so again, this is what they're going to give you: constrictive pericarditis and your restrictive cardiomyopathy. And you look at your hepatic vein flow with expiration, you get an increase in your atrial flow reversal. And then with restrictive cardiomyopathy, you get an increase in the atrial flow reversal with inspiration. Okay, all right, and then but the other distinguishing thing is your tissue Doppler. So if you get your tissue Doppler, constrictive pericarditis, you're going to get a big E prime because it's not a muscle disease, whereas your restrictive cardiomyopathy, small E prime because it is a muscle disease. Okay, and you can get your pseudonormal or your restrictive uh, pattern in your mitral inflow. You'll get a very large E and a small A. All right, so you have to know to distinguish them. Again, hepatic vein flow with inspiration, you get an increase in your atrial flow reversal with inspiration, whereas your your constrictive pericarditis, this increase atrial flow reversal occurs in expiration. All right. All right. So we're gonna leave the others for another session. So we look at your dilated cardiomyopathy, we look at your hypertrophic cardiomyopathy and restrictive cardiomyopathy. Our next session, we will look at your arrhythmogenic right ventricular hypertrophy and non-compaction. Um, so